Good morning, everyone. I guess we're finished playing musical chairs here. We're going to run this kind of like a tag team match. It's a short presentation, and there are two of us. So let's see how this works. Attila and I are going to talk about the DHS and MNCH programs to give a little bit of background about each of those programs, and then we'll get into the meat of the presentation. The title of the presentation is The State of the Art. And I think this is important because even though we all know that survey research is a science, there's an awful lot of art to it, and particularly in designing questionnaires and coming up with appropriate wording for survey questions. The DHS surveys, just to give you a little bit of background, have been conducted in more than 90 countries, and there have been more than 300 surveys when we count all the different types. And you probably can't see the legend here, but the red countries are surveys that have included HIV testing. And actually, biomarker testing has become very common in almost all of our surveys. It's sort of second nature to us now. And when we actually counted up how many biomarker tests have been done in DHS surveys, I think we ourselves were surprised to find out that it was more than 5.7 million biomarker tests. So that's a very important component of the surveys nowadays. As mentioned before, the project started in 1984 with core funding from USAID, and the program also receives additional funding from development partners, other development partners, as well as from country governments. The program is coordinated by ICF International. And I just should mention that the DHS project includes not just demographic and health surveys, but also AIDS indicator surveys, malaria indicator surveys, and service provision assessment surveys, which we call SPA surveys, and these are health facility surveys.
The multiple indicator cluster surveys, on the other hand, have been in existence since 1995, and they have been conducted in more than 100 countries. And we have conducted around 240 surveys during this period. On the map, you can see the countries where MNCH has been conducted. Those shown with dark green are those which have been conducted in the last 3 years. The multiple indicator cluster surveys were developed by UNICEF in the early 1990s, basically to respond to data needs for the World Summit for Children goals. Funding comes from UNICEF, other UN agencies, and development partners, as well as governments. And technical support, in the case of MNCH, is provided by UNICEF headquarters, the regional offices and field offices of UNICEF, and household survey experts who work with us.
So I'm going to say a little bit about the role of the DHS and MNCH surveys and the use of these surveys. DHS and MNCH have played a major role in shaping the global agenda on tracking MNCH coverage and populating global databases. And just as one example of that, if you look at the UNICEF global databases, DHS and MNCH account for 98% of the information on the use of oral rehydration salt solution together with continued feeding, and 82% of the information on skilled attendance at birth. And there are other indicators that are similarly high. In terms of the use, these data are very widely used, as you probably know. One reason for that is that the data sets are freely accessible publicly at no cost. In a standard format, and I think the standard format is very important. It really allows users to make use of multiple data sets more easily, and a lot of user support. We spend a lot of time and effort answering questions from users. Secondly, the PLOS Med collection is one example of the use in the literature, but actually there have been more than 1,500 articles in peer-reviewed journals in the last 10 years alone that use DHS and mixed data as the major source of data for those articles. Both programs also have a compiler, the DHS stat compiler and the mix compiler, and these compilers allow users to create custom-made tables of estimates of key indicators by selected background characteristics. We also spend a great deal of time harmonizing the two survey programs, and we collaborate closely and work through interagency processes to ensure that the survey tools and methodologies are harmonized and comparable. And this allows the calculation of key indicators in a standard fashion so that they can be compared across countries and over time, no matter which of the two types of surveys have been done in these countries.
There are differences, of course. There are many similarities. Both survey programs include a lot of questions on fertility, mortality, and on most MNCH indicators, the list of which would be too long to go through here. But there are differences in content too. In the case of DHS, there are biomarkers, questions, modules on sexually transmitted diseases, domestic violence, women's empowerment, and there are detailed questions on reproductive health and family planning. In the case of MIX, there's more emphasis on child protection related indicators such as child labor, discipline, early childhood development, and we also include questions on the knowledge of danger signs for illness. Another difference between the survey programs is the mode of technical assistance that is provided by the two programs to the countries conducting the surveys. Both programs encourage South-to-South cooperation. Both survey programs do have technical visits to the countries, but in addition, UNICEF provides technical and logistical assistance to the countries through its field offices and through regional workshops. Some other major differences include the way that we deal with children living in the households. In the case of DHS, MNCH data is collected only on the biological children of interviewed women. In the case of MIX, all children living in the households, including orphans and foster children, are covered via a questionnaire on under 5 children. However, according to our analyses, this does not seem to have any substantial influence on the national estimates. Another difference is that DHS surveys generate information on births during the last 5 years preceding the surveys, while MIX uses a 2-year reference period. This has implications, obviously, for sample sizes and reference periods of the coverage indicators produced by the two surveys. In our paper, we also discuss some of the strengths and the weaknesses of the two survey programs or these household surveys. For both DHS and MIX, data quality is a foremost consideration when designing the surveys and implementing them. The major strength of both programs is the incorporation of quality control mechanisms at every step in the survey process. This includes those processes of sampling, training, supervision, data processing, and extends to the dissemination of results. There are certain challenges and limitations, many of which we are all aware of. There are challenges in many cases in the adaptation of standard protocols to the country context because of the sophistication and the long list of things that need to be adapted. Heaping, rounding, and displacement, out-transference of ages, dates, remains to be a problem in some of our surveys. And we note that questionnaire sizes for both programs are now approaching lengths that may adversely affect data quality. Finally, estimates at lower administrative levels, such as districts, slums, and small population groups, are usually not available from our surveys, but in some cases, oversampling is used to generate such data at the very low administrative levels. To conclude with, in our paper, we present 5 key points. And here are the key points. DHS and MNCH are the principal source of data on MNCH indicators in low and middle income countries. And household surveys are likely to remain, as has been indicated before, the primary source of data for the foreseeable future, despite efforts to improve routine information systems. And to analyze estimates over time and across countries from household survey data, it is essential that similar methods and questions be employed to ensure this kind of comparability. Strengths of and weaknesses of all data collection efforts need to be transparent and well understood by data users. And finally, DHS and MNCH will continue to benefit from methodological research, such as those found in this collection, to make further improvements in the collection of MNCH data. So from me and Fred, thank you very much for your attention.
So I think that brings us now to our first discussion period. And although the opening speakers have disappeared and are not beside me, you are welcome to address your questions. They're Elizabeth, Mariam, and Jocelyn. So just please remember, I think we have a free mic that belongs over in this side somewhere. Okay. So if you'll raise your hand, Brandon will bring you the mic if you're on this side. If you're on this side, please approach the microphone to pose your question or comment. We welcome comments as well. Please identify yourself clearly using the microphone for people who are not in the room with us.
Hi, I'm Troy Jacobs from USAID. That was very nice presentations, and this is a much welcome series. This is an issue that I've discussed with some of you before, but Jennifer, it was striking when you were describing a number of sort of factors or barriers that were sort of affecting how we measure and obtain coverage. One that was missing that I think is very important, because I suspect looking around the room, most of us are data users and not as involved as, say, you are in data analysis. And it's easy to ignore or not be aware of the role of capacity. And I think that as we move forward with MNCH or DHS or whatever way we understand the world in terms of coverage, we need to think about capacity for doing this type of activity and how that is going to be configured and what it's going to look like. And I know you have lots of thoughts of that, and there's probably others in the room that have thoughts as well. But I think that's an important factor that was missing, but I know it's there in the back of your head.
Thank you, Troy. Why don't we, I think, take several questions, and then we'll share the responses. And you're welcome to respond to, for example, someone can respond to Troy's question if they would comment if they would like. I'm gonna wait them out. David, and then Lisa.
I'll help you out here, Jennifer. David Oot from Save the Children. I guess what was going through my mind is, first of all, I'm a big fan of coverage surveys. I don't know what we'd be able to say about, what we're doing, what we've achieved, where the gaps are without them. The question that was going through my mind is, it seems to me we talk about coverage gaps. We've actually got a survey coverage gap. And I wonder if we could speak to that. There are places where they either haven't been done recently enough, or they haven't been done over a very extended period of time. And so how do we address that issue? Then related to that is is there an ideal interval? And I guess how do DHS and MICS sort of work with each other to coordinate efforts to achieve some kind of an ideal interval between coverage surveys, knowing that these are costly and time-consuming, and a lot of time and effort goes into them. Thanks.
Very good. Thank you, David. Lisa, let's take one more from you, and then we'll pause and discuss.
Yeah, hi, Lisa Lee on behalf of the Gavi Alliance. I'm also a very big fan of the DHS and mixed surveys. I use the data all the time. And I think it's been interesting to see how they've gotten bigger and bigger in terms of what program managers need in getting precise estimates at lower and lower administrative levels. And I just wanted to raise a comment, and I'd be interested in hearing people's comments about it. And it relates to getting even finer levels of measurements at the community level. At least for immunizations, the goal has really been now to move away from reaching every district to reaching every community, and how to leverage things like national campaigns and the quick, campaign surveys to really develop inventories, national inventories of high-risk communities where the household coverage surveys are very ad hoc, non-representative. And the goal isn't really to measure coverage precisely, but to validate an inventory of high-risk communities that the program managers should be targeting for focused outreach or increased efforts to increase demand.
Thank you. All right, I'm going to, our experts to my left, and I also welcome Tessa Wardlaw is here, who is the chief or the director or something like that of the Statistics and Monitoring Unit. So go ahead, Attila and Fred.
I'll start this first one. So thank you, Troy. I think we are always aware of the fact that our basic job is to work ourselves out of a job. And the idea behind that is to take capacity building to a level at which countries are fully able to collect survey data, process survey data, and analyze survey data on their own. There are certain realities in various countries about how this can proceed. We do a lot of capacity building. We always have, both programs. A lot of on-the-job training, which I don't think we get much credit for, but that is essentially how we get people up to snuff. There are several countries where basically they don't really need technical assistance to a large extent anymore, such as Indonesia and Peru and the Philippines. And there are others that over the years have used a lot less technical assistance in particular areas. I think it's really the areas of sampling and to some extent data processing that are the last for countries to take over entirely on their own. I would say most of the countries we work in are perfectly capable of conducting a survey, implementing a survey on their own. We just keep moving along that line. Some of the assistance, by the way, is not of a technical nature. It's to keep things moving. Everybody in the survey organizations is doing 100 different things at once. They're pulled in many different directions, and it's hard to get them, no matter what their technical expertise is, it's hard to get them to focus on a particular survey and move things along. So actually part of what we do is that. It's not just technical assistance.
Well, in addition to agreeing to everything that Fred has said, I do think that we sometimes underestimate the capacity at the country level. There's a lot of capacity that has been created at the country level. And we see ourselves as supporting countries not because there's lack of capacity, but there's a need to coordinate and make sure that comparability is maintained across countries. And for that, some kind of coordination efforts and technical efforts need to be in place. I don't think we have the big problem of lack of capacity. There's huge capacity. Both programs, as well as others, have done much over years to really build capacity, develop capacity at the country level, and it is there. Yes, there are some areas such as those that Fred has already mentioned, like data processing, sampling, but even in those, I think we are seeing more and more capacity at the country level. But that doesn't mean that every country would start to go their own way and create their own indicators. We'd suddenly lose all kinds of comparability. We start not to make sense of what's happening in a comparable fashion in this global village. So there needs to be some kind of standardization and comparability, and that's why this kind of technical work needs to remain in place. In terms of the intervals between surveys, there's something interesting which has happened over the last 5-6 years that as the mixed program, we've been very happy to see. There's a number of countries now. Typically DHS in most countries are conducted every 5 years, that kind of period, and that used to be the case with mixed too. There's a number of countries now, those countries where the indicators seem to be, interventions seem to be very intense, and indicators seem to be changing quite fast, much faster than one would expect under normal circumstances. There's several countries where we have now a mix and a DHS and a mix and a DHS. Both programs, both surveys are being implemented, obviously with 2 or 3 year intervals rather than 5, which brings a lot of advantage to having, to increasing the periodicity of data, but also making sure, thanks to the standardization and harmonization efforts that we have gone through over the years, that doing these 2 surveys within 2 or 3 years of intervals really still comes up with comparable data. That is happening, and for some countries, such as Ghana, for instance, and there's a number of other countries in the same situation, we are able to do that. The lower administrative levels, generating information at the community level or lower levels, remains to be a problem. I don't think household surveys are going to be necessarily the answer to that, to all kinds of data needs at that level. There are cases, as we have indicated in the paper as well, that we oversample, for instance, certain population groups, or in the case of mix, we have more and more surveys now which are only confined to certain areas of the country with significant sample sizes, which enables us to go deeper into the lower administrative levels, at least for that region of the country, for instance. But overall, I think, I may say this on behalf of both of us, that continuously increasing the sample sizes and trying to get lower administrative level information may have a risk in terms of the quality of household surveys. So we have to be really modest in terms of our expectations at those levels for data.
I'm going to use my prerogative to press harder, because I work in Countdown for those 75 countries, and we do look at those 75 countries, and countries that don't have a mix or a DHS are operating in the dark. I'm thinking of countries, especially small Francophone West African countries, Togo. The last time there was a mix or a DHS, I believe, was 2006. And I know that your resources, human and financial, are limited. However, I'm pushing harder here to say, what are we going to do about that? And we're having a conflict in that some of us are saying countries need solid data at lower levels, and yet you're faced, again, with resources and perhaps a limitation in the just overall complexity that is possible. So how do we find, as a community, as a public health community, how do we find our way through these two things? And I'd like to hear from you, it's kind of a mystery to the rest of us, how you're good. You sit down and you say, okay, which country, or who's going to take which country, and which are the biggest needs. I'm worried about those that fall off the bottom of the list. I don't know if you have anything you can say about that. No, okay, Tessa.
Well, good morning, everyone. I just really, in the context of discussing this, wanted to mention what's happening over the next couple of years, because these household surveys, as you know, are critically important for the final MDG assessment, which is going to happen in September of 2015. So we've been engaged in a fairly comprehensive exercise using our network of field offices and our regional offices to sit down with national governments and really to make a fairly comprehensive assessment of data gaps and then determine how countries are planning to fill those data gaps for the final MDG reporting and whether or not a mix or a DHS survey is warranted. So I think what you can anticipate over the next year, 2 years, is a huge influx of survey data for that particular purpose. So I did want to bring that into this discussion. Thank you.
Thank you. Thank you. And we have time for another quick round if you have any questions. Yes, Brandon, we've got someone right here. He's coming.
Good morning. My name is Anthony Duttine. I work for Handicap International. So my question, quite unsurprisingly, is going to be around disability. And I know that the mix certainly has a set of questions around disability, and that's being revised. I've been working and following a little bit on the revisions. But given sort of new trends and new emergencies in global health, where we're looking at more prevalence of morbidity and disability, I want to know what the future of household surveys might look like, particularly measuring these new trends that are coming through.
Thank you. Dale.
Go ahead.
Oh, there.
Oh, sorry.
I was just
sorry.
making sure, do we have any other questions or comments? Okay. Go ahead and move.
Yep. As you have pointed out, we have been working on the issue of disability for some time now. We had a set of questions, screening questions on disability in the second and third round of mix. But then we have now gone into a new effort to really revisit those questions, the screening questions, try to see if we can revalidate them. And we have been working with the Washington Group, which is a group which works under the Statistical Commission, to generate new questions, better validated questions, so that we can generate information at that level in the household surveys. There's also an issue of medical assessment, of course. The collection of information on disabilities through a household survey only is not the sole answer. We have to really do the medical assessment, we think, following household surveys, and that's also something that we have been working on. I know also that nowadays WHO is in the process of developing a model disability survey instrument that will probably be ready by the end of the year. So there's a number of initiatives in this regard, in this area. Let's see what the future will hold for us.
Thank you. And we're doing quite well on time, and what I suggest is it's 10:40 about now. So why don't we take a break